Test 1 1, test 1 1.
Good.
Test 1 2, test 1 2.
Good. You know that's good now.
Test 1 3, test 1 3.
Yeah. Good.
So we still need, do we need? All right, it is 1 o'clock. Okay. Okay, we're going to go ahead and get started with the meeting. We have not made quorum yet, so we're going to have to move a few things down in hopes that we have a couple more folks show up, but we can do the non-action items. So I'll go ahead and call the meeting to order. Meeting of the Quality Committee. First thing, citizens wishing to address the committee. I've been told there are none, and it looks like there are none. So we will go, we will have to skip over the approval of minutes. We do not have a quorum to vote on that yet. So we will go down to the quality reports and updates not requiring committee actions. Dr. Richard Miller. Good afternoon.
Good afternoon, how are you?
Good, good. Welcome.
Do we bring the representatives in for the, I thought there was quite a few of them out there. So we're going to report the August, September, and October 2022 Dr. Charles E. Weber Jr. Golden Mid Awards. The August Award, the recipients of the August Award was our Spiritual Care and Ethics Department, here represented by Leanne Franklin and Laura Burnside. They were nominated by Dr. Gandhi and the Patient Safety and Quality Governance Committee. And let me just give you a few of the reasons this group of amazing professionals were nominated. They're here in the hospital 24/7, always available. They're affable, and they're able to help us and our families. Nothing gets through your mitt. They take care of all of us as staff, whether it's by love bombs, debriefs, coffee clutches after a very stressful event, of which we have many here. They're always there. They supply us with food, they supply us with candy, reading material, and most importantly, they supply us with hugs. And if you know me, I love hugs. They're always there for our families as well. They support more than the usual spiritual care. They help our families understand what's going on. They translate our medical lingo into the vernacular, so our patients and families can understand the language of medicine. And when our patients and our families understand what's going on, then we're truly able to make shared decisions together with our medical staff. They're always smiling, they have a servant's heart, and they help every one of us every day in everything we do. Through these efforts of spiritual care and ethics, they receive the August Golden Mitt Award. Thank you so much.
Congratulations.
Our September recipient of the Charles E. Weber Golden Mitt Award was the main operating room, represented by Deb Saunders, Marcy Walker, and who else do we have here? Just Deb? That's good enough. A place that's very dear to my heart since I've been operating for over 35 years, and that's after residency. They were nominated by the Clinical Risk and Infectious Prevention Departments, and here are some of the a few reasons for these amazing professionals were nominated. Over the last 7 months, the operating room has maintained an increase in patient safety event reporting. Staff are reporting a lot more near-miss events and events that have never resulted in any serious harm, which really demonstrates their dedication to and their awareness of patient safety. They've been engaged in discussions and participated in action planning and implementation implementation of interventions to mitigate the rise of pressure-related injuries. We have it as part of our huddle now. If a case is a prolonged period of time, we make sure we have the padding in place and any other related injuries to patient care during the operation. The OR has done a great job during this year with the scope pre-cleaning process and prove that they could do even better than staying consistently 100% compliant during scope audits since this March. They're actively involved in several committees to reduce soft tissue infections, especially with colon surgery and hospital-acquired infections, especially CAUTIs and CLAPSIs. They've been a huge asset to our quality department. And most importantly, from my standpoint, throughout all our trials and tribulations over the last several years with COVID, we've been able to maintain running our ORs and taking care of patients that needed operations. And in order to do that required tremendous changes and challenges both at Jessica and here at the main operating room. And despite COVID, the number of cases and procedures we're doing in both Jessica and the OR has gone up exponentially. So, for all of those reasons, the OR has been the recipient of the September Golden Mid Award. Congratulations.
Congratulations.
And last but not least, the October award went to the OB triage and labor and delivery departments, and I think Pam Gessling's here, Jessica Weathers, and Jen Tharp Johnson, right? Are you all here? Congratulations. So, let me tell you a few of the reasons why this group of amazing professionals was nominated. Postpartum hemorrhage rate is the lowest it's been since we started quantitative blood losses many moons ago at 7.944%. That is extremely low. The decision to incision on emergency C-sections averaged 9 minutes. 9 minutes in FY22. That is extremely quick. Delivery numbers are the highest they've been since fiscal year 18 with 300, and actually it's over 400 deliveries in October. Is that correct? See, I just listened to your report. 4,051 deliveries in fiscal year 22. Those are amazing numbers. OB triage visits are up 1,300 visits in fiscal year 22 when compared to 9,366. So over 400 more OB triage evaluations. And as we all know, they have been very successful in maternal levels of care survey with absolutely no deficiencies. And so through all their efforts in OB, triage, labor and delivery department, the October Golden Mid Award went to this great team. Congratulations. Thank you, Mr. Chair, Dr. Chair.
Thank you, Dr. Miller, and for all of our recipients, congratulations. Okay, we now have a quorum. Since we now have a quorum, I'll circle back and entertain a motion to approve the minutes from our previous meeting, August 8th. So moved. Do I have a second?
Second.
Second. All in favor signify by aye. Aye. Any opposed? Motion passes. Okay, we will jump back down to True North, our patients. Emergency services, I believe, is next. Farrell and Dr. Jessica Kirby.
Dr. Kirby, come on down. Jill is out today, so Jessica will take the reins and be able to go through this full presentation. This presentation is part of the conversation we had around Left Without Being Seen. The board had asked that we return and speak a little bit about the work that we're doing around Left Without Being Seen. Jessica will present not only the work that's being done around Left Without Being Seen, but more importantly, the work that's going on in the ED, which is greater than just Left Without Being Seen. So thank you, Jessica.
Thank you, Dr. Duncan. And hello, thank you so much for having me this afternoon. As Dr. Duncan said, I'm Dr. Kirby, and I'm the medical director of the ER. It is absolutely our pleasure in the ED to partner with the Health Network. As you know, we are one of 7 safety net hospitals within the state of Texas. We have 582 licensed beds, and I hope at the end of this presentation, you will appreciate that we can use many, many more. We are the only county hospital in the country to have a comprehensive stroke program, have a level 1 trauma program, and have a AMI certified program by the Joint Commission. We have 67 care spaces in the ED, and we have 40 additional spaces that we're able to make available for our patients. We recognize that the ED is the front door of the JPS Health Network, and we strive to ensure that with every patient, they see the mission, vision, and values of our network. Thank you. Thank you so much. That's perfect. You may or may not know that we are actually the 14th busiest ED in the entire country. 14th busiest ED. We hit our peak volume in fiscal year 2019 when we saw 125,000 patients. Our volumes have been slightly lower for the last couple fiscal years, and this is simply related to the impact of COVID. Daily in the ED, we see about 320 patients a day. On Mondays, we may see up to 400 plus patients a day. Puts it in perspective a little bit. So how do we compare when you put us against other hospitals in the country? When you look at national ED admission rates, data according to the Emergency Department Benchmarking Association gives us a range of 19% of patients get admitted to 36%. In fiscal year 22, we were at 24.8%. This puts us slightly below the median admission rate. And this is quite remarkable because remember, I just told you before, we have a trauma center, we're a referral center, we have high acuity, high volume. You'd actually expect this rate to be quite a bit higher. And we're just below the median rate, which I think you guys should take away is we are being good stewards of our resources and not admitting patients that don't need admission, but rather connecting them with our outpatient programs. What about boarding time? This is something I think is really important for you as board members to understand. I think this is one of the greatest inhibiting factors, or said differently, one of our greatest opportunities as a health network. National ED boarding time ranges from about 61 minutes to 666 minutes. If you remember, boarding time is typically shown in minutes, and it's the time that a patient is admitted but physically remains in an ED bed. And the disadvantage to that is that because they're in the ED bed, we have a patient in our waiting room that we don't even have an opportunity to see because that bed is occupied. So median boarding time is 253 minutes. Our time in JPS for fiscal year 21 was higher than that. It was 354. So this is where I think we have the greatest opportunity. We occupied a very high capacity rate, and that's something that Bill Masterson can speak to more gracefully than I can. But know that we are very efficient in the work that we do here at the Health Network, and we are always at a very high capacity rate, and yet we still have a number of patients that sit in the ED that we're unable to get to a bed upstairs because there's simply not enough room.
Could I ask you a question before you move from that slide? This is from the time the patient enters and to the time the patient is dismissed from the ER to go to a hospital bed.
That's correct.
Okay, all right.
Yeah, so for 354 minutes, a patient has been admitted and is sitting waiting to go up to a bed.
Okay, all right. Just wanted.
Yes, you are correct. You got it. So how do we compare in regard to left without completing treatment? I want to break down this term for you a little bit further. So left without completing treatment means any patient who leaves before treatment is complete. So this is going to include left without being seen, but also patients who elope and patients who leave AMA. So patients who elope are patients who are seen and for whatever reason decide they don't want to complete their care. They realize that their daughter's going to come off the bus and they want to be home to meet their daughter, and they've decided they need to leave. That's eloped. Someone who leaves against medical advice is someone that we have seen, evaluated, and we've determined needs additional testing or needs additional care. We've gone over with them the risks of leaving, the benefits of staying, alternatives to staying, and they still, despite that conversation, decide to leave against medical advice. That's when they leave AMA. So nationally, when we talk about left without completing treatment, this encompasses all of those patients who either leave before they're seen, leave after they're seen, or leave even though we tell them we really want you to stay. So nationally, left without completing treatment ranges from about 1.6% to 14%. And this number is very relative based on your volume, based on your acuity, based on the services that you offer, and you'd expect it to be higher for these higher acuity, higher volume centers. So median is 5.1%. We were slightly above that last year at 6.5%. Before COVID, I will tell you that the factor that correlated closest to left without being seen was our boarding rate, which is what we talked about on the last slide. Since COVID, we've seen a few other variables, such as staffing, limited resources, and other things. But boarding plays a significant role in our ability to care for new people who walk in the door.
Dr. Kirby had a quick question on that slide. What is the gray box? The blue is left without being seen, orange is AMA, and what is the gray box?
The gray box are the eloped. So
Perfect.
again, patients who were seen and then chose to leave without notifying us and just walk out.
Thank you.
Yes. Yes, sir.
We may have referred. I mean, a person comes into emergency, but they're not emergency, they are the urgent care. So does this show where we might have referred them to urgent care, or if they come to emergency, they don't get referred to urgent care?
This does not show the patients that we could have sent to urgent care. This just looks at patients who left for one reason or another. We've looked at a few different processes to what we call MSE to urgent care. Most of the patients who come are actually too sick to be MSE'd to urgent care or screened to go to urgent care. But to answer your question, no, this specifically shows patients who left, not patients who we said you can go to urgent care.
Okay.
And Jess, I'm sorry, one more question. The database that you're quoting for national statistics, is that an academic medical center, or is that just an across-the-board peer?
I believe this is for like-size institutions. And that's a great question. Thank you for asking that. That's part of the challenge. It's really hard. We don't really have apples to apples, right? There are very few centers in the country that are county hospitals that see the volume and acuity that we do, that have residencies, that have a trauma center. So we're kind of in a league of our own, but when you compare us to as much of a like-size facility as we can, this is where they're at, and we're just slightly above that. Yeah. And again, I think it's because of boarding. All right, we're going to shift gears just a little bit. As you know, MedStar is the EMS organization within our county that delivers patients to hospitals in our area. And this talks about where those patients are taken. So it goes from November of 2019 until September of 22, and we are the yellow highlighted line on the top. So MedStar actually brings more patients to JPS ER than any other ER in the country. The line right below that is THR Fort Worth. And I'd like to think it's because they know that they receive stellar care in our ED and that we treat our EMS folks with great respect.
Have we asked MedStar why?
Why they bring us so many other patients? Some of it's related to trauma designation. Some of it's related to stroke designation. Thirdly would be patient preference, and a lot of our patients actually ask to come to JPS. And then there are some other reasons beyond that. So what's going on with the acuity, or the level of sickness in our department. I will tell you it's trending in a direction that we would like. So on the left, we see fiscal year 18. On the right, we see fiscal year 22. And I will tell you that, well, let me orient you to the graph just a little bit more. So this orange color is high acuity, so ESI 1 or 2, those are heart attack patients, patients with significant shortness of breath. They're very, very sick. The blue graph, or blue bar, is our medium acuity patients, what we call ESI 3. This is going to be some of your chest pain patients, but also your belly pain, some of your difficulty breathing. And then the gray line is lower acuity, we call it ESI 4 and 5. This is the lowest acuity patients. Kind of equate these more to an urgent care visit, so a sore throat, a rash, a medication refill. And what you'll see is that our higher acuity volume went up. So it was 26% of our volume in fiscal year 18, and now it's 30% of our volume. And this is really what we want to see. We want the ER to be used for these high acuity, very sick visits. That's what we do, and that's what we want in the ER. In that same time period, we saw the lower acuity visits decrease. They went from 15% to 10%. And again, that's exactly what we want to see. We want those lower acuity visits going to the urgent care. We want them going to the family health center. We want them in the appropriate venue, and this is exactly what we want to see in our acuity. I will tell you that this also matches a national trend that we've seen after COVID, and that's that we're seeing less low acuity visits in the ED and less PEDS visits. We don't get much PEDS anyway, so we're not as affected by that, but this is a national trend, less lower acuity in the ED. So what are some general operational improvements that we've done in the department in the past year? We have worked on our capacity plan, or our surge plan. This is a plan that we've created within the department. So when we reach a certain number of admission holds, or a certain number of patients waiting in the lobby to be seen, we have a stair-step approach to people we notify, areas we open, resources we reach out to ensure we can continue moving in a forward fashion. But not only did we update our capacity plan this year, we partnered with the network to help create and modify a network capacity plan. So what that means is we're no longer working in silo, that we have a plan when we hit a certain level. We actually have a mirrored plan on the network side for improving throughput on the house side when we get overwhelmed. We've also worked with the PEC on their capacity plan. We've done a lot with data transparency. As you can imagine, in COVID, our team was really tired. The techs, the nurses, the docs, it was exhausting. And it was a really hard transition to take the team from caring for sick COVID patients exhausted to a new focus on patient experience and a new focus on throughput. So we've done a lot of work on data transparency and ensuring the team understands our goals, ensuring that the results are posted, praising the team when they reach their goals, and making it very public so they see the rewards of their work. We've increased huddles, so at least 4 times a day the physicians and nurses collaborate. We meet in the charting area and talk about barriers to getting patients through, things that went well the day before that we want to repeat, and things that are still opportunities for us. We worked on hospital throughput initiatives with the hospital. Jill Farrell and her team, and Dr. Assad, and all of the inpatient teams, we've worked very closely with them to improve efficiency on the inpatient side. And we've done a lot of work on security. As you know, security has been a top concern in the ED and with healthcare workers, and we've spent a lot of time, thank you, Dr. Duncan, with improving our security and police force in the department. Beyond just seeing patients, we want to ensure that we provide quality care to our patients, and we're very proud of the quality that we offer in our emergency department. We had a really fun experience with COVID in that we were able to send patients to an outpatient COVID monitoring program. So this is something that was unique and we had not done previous. Never in my career as an ER physician did I ever think I would send a patient home with a pulse ox of 88%. And the first time ever, we had to do things we had never done before. So we had this beautiful collaboration with the case management program that we had it set up that they could receive oxygen at home, phone calls at home, and patients were safely discharged that 3 months previously would have been admitted. it was a successful program, wildly successful, and we decided to kind of extrapolate that to other programs. And we picked a specific disease process or diagnosis of CHF, and we decided to extrapolate this idea to CHF. So we said, is there a specific patient that we can avoid unnecessary admissions by putting algorithms in place for the workup, algorithms in place for who we admit and who we put in observation, and then can we set up defined access to another case management program like the COVID case management program that patients could successfully be cared for in the outpatient setting. And what you'll see is we were successful. So if you look at July, we discharged 16% of this population, and then by September we had discharged 32%. So we actually were able to discharge a significantly larger number of patients by following this algorithmic approach and having support on the case management family medicine side. All right, I'm going to put my Jill Farrell hat on for this one. So bear with me. I wanted to share a little bit with you in regard to the RN workforce in the emergency department. So needless to say, during COVID and thereafter, we have seen a significant turnover in the nursing workforce. This was seen even greater in the areas of emergency care and critical care. Well, how did this affect the JPS ER? What was our turnover percent in 2021? It was 62%. We've worked really hard to retain our staff, and we got that number down in fiscal year 22 to 47%. In fiscal year 21, we had 77 open nursing positions, and by the end of 22, we've been able to decrease that number significantly to 38, so we're much better staffed than we ever have been. But I want you guys to know that this is an ongoing concern, an ongoing challenge, and to retain talented nurses and keep them engaged and keep those FTEs full and staffed has been really hard. I think will continue to be hard in this next year. And finally, staff engagement. So like I said, we've kind of gone from this period where everyone is exhausted to trying to re-engage the team and make them feel a part of the team. And so what are some ways that we've done that? We've done some work with what we call our unit-based councils. So we've encouraged our nurses to participate in some of these unit-based council programs and decisions. We've increased leadership on the floor, rounding, and being part of the huddles that I had mentioned earlier. We've increased our recognition programs. We've reinstated our peer support programs, and we're doing a lot of work on leadership development. And here's some pictures of our team, both at work and at play. We've done a few socials for the team. In fact, last weekend, we invited all the nurses, techs, and docs to go out to a Dallas Stars game just to have some camaraderie together and build the team socially outside of work. And I think we're going to get some really great returns from that team building that we've done together.
So you want to go to Cal?
Oh, those tickets are too valuable. So that's the presentation I have for you. What questions do you guys still have remaining in regards to anything you've seen or heard? What can I answer for you?
Well, I think you did a good job of explaining your information, and I want to thank you for that. And your information was pretty clear to me, and I just think that y'all are doing a great job. I had the opportunity my sister had to come through the ER, and I could not compliment the staff more on their work and their care, and it just was a beautiful experience, and I thank y'all for that.
Thank you. Thank you so much. I appreciate that.
Besides our board rate or board time, where do you see the nursing shortage play into this right now?
I wish I had a numerical number that I could give you. I will tell you it does play into this. I think the boarding is most directly affected by the number of beds within the house and our ability to get patients up to those beds, but the nursing shortage has definitely been a factor in this because they're necessary for the care, and without those nursing FTEs or the nurses present, we simply can't do our good work. Yeah.
Yeah, there are many factors, I think, that play into the board rate or the board time. Of course, getting patients available for discharge to open beds up. So I remember back when I was training, that was sometimes one of the factors in actually being able to move people up from the ER. And some of that can be held up sometimes by the time it takes maybe to get diagnostic studies or consults. There's all kinds of factors that go into that.
We have looked into that because you're exactly right. You also have to look at the time it takes to discharge a patient. And one of our longest times to discharge is actually related to our consult turnaround time. So we started a very robust project with our consultants, and we've shared with them our desire to decrease that turnaround time and to more quickly understand their plan, and we're actively working on that. We are also following the time it takes from us to mark a discharge until the patient leaves the department, the goal being 30 minutes or less, and that number is decreasing over time as well. We have not looked at turnaround time of lab or radiology at this point. That really, on a gross examination, has not been a factor in limiting our throughput. But when we get a handle on some of these other things, we can certainly narrow in a little bit more on some of those other items like lab, radiology. But right now, our own internal, the discharge time, as you mentioned, and decision time are kind of what we're focusing on.
Anybody have any other questions? No? Thank you so much.
Thank you, I appreciate it.
Okay, next we have patient experience. Laura Burnside. Laura, welcome.
So before Laura gets started, I would like to inform the board that Laura is going to start a new chapter in her career, and she will be leaving the organization in December. Laura has been with us now for a little bit over 7 years. She has overseen our patient experience and is often thought of as the person over patient experience, even though it is all teamwork. But more importantly, she has filled in to take on some other needs of the organization. Most importantly, she has led a lot of the work on physician engagement, which I see to be one of the heaviest lifts the organization has made and continues to work through. I will miss Laura when we have our crisis, such as our ice storm or even during COVID, that she could just turn on operations and make sure that our staff had beds to sleep in, cots to sleep in, had food, all of that really put the employee and our patients at the center of what we needed during those times. So I did want to inform the board, Laura, we will truly miss you. You've given a great 7 years of time to JPS, and we wish you the best.
Thank you very much. It's been an honor and a privilege to walk this journey. There are extraordinary people here who do extraordinary things that, unless you're on the inside and really see the activities and the actions and the behaviors of those that work here, you truly can't understand it. But I will share, last week I was actually speaking on a panel, and unbeknownst to me, the panelist sitting next to me had quite a story to tell. And so we were introducing ourselves, and I went first and started explaining I work at JPS, and we are the public hospital for Tarrant County in Texas, and yet we've tried to do everything that we can to bring value and honor and comfort and respect to every single person when they walk through our door, whether they work here or they're receiving care here. And as I completed my introduction and it was his turn, he said, I'm going to introduce myself, but before I do that, I need all of you to know that what she just said is exactly true. And my dad was a patient in that hospital 8 months ago, and he passed away. And this gentleman lives out of state, and he said, I was flying in to make sure that everything was okay with my dad while he was there, and it was a very horrible experience for his family. It was a tragedy within their family. And so he said, I made several trips down over the course of time that his dad was a patient in here, and very quickly realized that he didn't need to. Because he said, the thing I felt overall was that my dad and my family were cared for. And that it wasn't just about the clinical care that was given, but it was the care and compassion and the passion that the people who work here have for the patients we serve that made a difference. And I had no idea that this gentleman had a parent in our hospital, nor would I have had any indication of that prior to. His dad passed away during that visit where he was here, and he said, you know, of all of the most horrible times in a family's life, I cannot thank you enough for what happened to my dad. And I just want you all to know that the work that you do and the work that this organization does means so much, not only to those within Tarrant County, but to those who we have the privilege to serve, even when they're all over the world. And the work that we've done to put in family meetings virtually or phone calls to families. He said he received a phone call every single day, and he would provide me with a list of those he could thank. I hadn't gotten that yet, but I will. But, you know, it could have been anyone here, and I think that's the message that I would like to share as I leave this organization. And I shared with Dr. Duncan last week that I have the utmost gratitude and appreciation for being fortunate enough and privileged, frankly, to work alongside all of you and this organization as we have done our darndest to take care of the patients and those who come through to work here. And so I thank you and want you to know that I am incredibly grateful. This has been an amazing 7-year journey. Yes.
I must say that there have been many times I serve a large congregation here in Fort Worth, and there have been many times I've had issues, and to keep from calling you and Robert and you, I called Laura, and there was not one time she did not immediately respond and handle the situation. So I think she need to hang on for a little while longer. I have some others. But I thank you so much.
It's my pleasure. It's been a pleasure. With that being said, I'm really excited about this presentation today, and I hope that as we go through it, you will again remember the incredible work that this team does and the work that that you all allow us to do. Your support is absolutely what we need in order to be able to serve in the way that we do. And so as we go through this, we had a really good year last year. Nationally, that was not the case. Nationally, what the other hospitals within the country experienced was a decline in patient experience, a fairly significant one. That's not what you're going to see in what happened here. So I'm excited to share and show you that we actually did achieve our stretch goal last year when we looked at the weighted average of these 6 areas. What I'm most excited about is it wasn't one area that improved. It was actually 5 out of the 6 areas. And we did see improvement over the last several months in the emergency department. It just wasn't significant enough to pull us over that on a yearly basis. But I suspect that based on what you just heard with Dr. Kirby's presentation, that you will see that change next year. They are incredibly focused and have a very solid action plan for the work that they are doing in the emergency department. But I'm really pleased to share that overall, again, as the nation declined, we did not. Why is kind of the question. And we have spent many, many years building foundational aspects when it comes to culture, when it comes to engagement levels of our team members, and when it comes to the foundational tactics and techniques that we use in order to best care for our patients when they come through. Why does that matter? Because when you hit a crisis, it's very common for people to come back in and do whatever is most comfortable to them, and that's not what we saw our team do. We saw our team still push forward with all of those things that we know are most important in serving our patient population. And so what this shows me is that the foundation is there, and it's quite solid. And so building upon that becomes a whole lot easier over the course of the next year or 2 or 3, because we didn't crumble. And I think that's a really important thing for you to know, and it's important for our teams to know that all of that solid work that's happened over the course of a decade of time really matters, and it mattered for us in the most critical moments for our patients. Some major increases, which you can see on the graphs there. Very proud of the inpatient side, the behavioral health side, the clinics. Everyone achieved over what was statistically significant even pre-COVID. And then again, when you look at what happened nationally, there was a decline. I wanted to follow up on a couple of things that we talked about the last month, I guess, when I presented. We have been working hard on patient access. It's also a key priority for us for this coming year. And through the work of the Network Access Steering Committee, of which Joy and I co-chair, there have been work groups that have been established to work on specific areas throughout our patient access journey. And when you look at the specialty areas that are listed on the chart on the left-hand side, those particular specialties had significant change over baseline when the work and tactics and techniques began being put in place. And those were things like managing inpatient in-baskets. While it's not perfect, we do now know that 75% of our messages are handled within 48 hours, which is a vast improvement. And so how that reflects to the patient is what they're finding is the ease of contacting the clinic has improved overall for these areas by 8.6 percentage points top box. Nationally, if we looked at the top performers in the country, not just safety net, but top performers, top 10% of the country, they moved the needle 5.63 top box percentage points. So our organization moved 8.6, which is huge. So great work going on within the clinics, and I anticipate that there will be additional clinics mentioned there as we continue and the work continues over the course of the coming year. The other thing that I wanted to follow up on is care transitions. As you know, this domain for us has been a lagging one. Most of our domains across the hospital come in the top of the country, meaning 75th percentile or above, or in other words, top 25% of the country. And care transitions has been a lagger for us. It's a difficult one nationally, but we actually moved the needle 2.8 percentage top box points, and the national average is 2.72. Again, top performers, top 10%. So we actually overperformed them in the care transitions domain as well. There is a work group and committee, a couple of them, that are working on all of the aspects related to this, and you can see that they are on the right track at this point, and I would suspect that that would continue over time. Key priorities for us for fiscal year 23 will be OAS CAPS. Public reporting begins on that in 2024. OAS CAPS is the ambulatory surgery CAPS survey that is distributed by CMS. We actually use that survey now, and there is action planning. You saw the wonderful work that the surgery area is doing, as they were recognized earlier by the Golden Mid Award. So great work will continue to come out of there. Patient access, as I just mentioned, is another key priority. Community health and the medical clinics are another key priority. And then inpatient always, because it is a publicly reported measure, and we do have reimbursements tied to that. That's always going to be on our radar. And then behavioral health, as you know, and then the emergency department. So we are working very diligently to increase survey response rates and also redesign the patient end-to-end interaction for all of our patients who come through, whether they're in-house, in the hospital, in the emergency department, the operating room, or in the clinics. So more to come on that. Press Ganey goes through our data, combs through it as closely as they can to follow all of the statistical analysis, and what they have come up with is that our areas of focus that will give us the biggest return for our patients overall is through the emergency services area, the medical practice offices or our clinics, and then ambulatory surgery. And so those are the three key areas that will be worked on. And then three things that they have recommended for JPS to focus on would be, number one, to define expectations very clearly on what is an excellent patient experience. And so, though we've done that in the past, they said time to revisit that and go through that again. Utilize empathy as a top priority, which will impact the courtesy and respect questions, listening, explaining, the communication domains, that kind of thing. And then really just assess the cultural aspects of the team. So, meaning employee engagement as a top priority, which it is for JPS, and making sure that we're tying employee engagement activities to patient experience through recognition events and the like, so that we can make sure that our team understands and appreciates the why behind the reason that they walk through our doors every day. And to that end, yes, sure, absolutely. Yes, not, so, yes, so that's actually all-encompassing, so it has to do with DEIB demographics, and it also has to do with the JPS rules of the road and really tying all of those pieces together, yes. And then key partnerships for us will be through the learning and organizational development team, the employee engagement team, quality and safety, which is directly tied to patient experience, and then continued work with the physicians and the APPs in order to make sure that we're doing all that we can in collaborating and cooperating together for the best for our patients. So I'm happy to answer any questions, but more than anything, I truly would like to thank you for your support over the years and for your dedication and commitment to serving our patients the best way that we can.
Any other questions?
Can you go back to your follow-up on patient access?
Sure.
And this is top box. So when I look at urology, their box would be 3.6.
That's their improvement.
That's their improvement.
Correct.
Okay.
Yes. And when you look at national data, on average, these areas improved by 0.44.
Okay.
We improved significantly higher than that, as you can see. But the very top of the country, those who are the best performers, moved this question by 5.63 top box percentage points. And again, we did that in most of these areas, but collectively we improved by 8.6 top box percentage point improvement.
All right. And you collect that information through the survey?
Through the survey,
It's easier
yeah.
for us to get an appointment. Oh.
That's correct. This is actually a question on the survey, and we know that the work that's being done reflects in that question, so that's kind of a measure of success, and so we've been monitoring that over the course of months, and we're starting to see that needle move significantly.
All right. Thank you.
My pleasure.
Any other questions? Thank you for your presentation, and thank you so much for your service to JPS.
My pleasure. Thank you so much. It's been an honor.
All right, next up, Dr. Miller returns. We have Leapfrog, Long-Term Incentive Plan, and PSI 90. Welcome back.
Thank you, Chair. Just before I start, I just want to reiterate the appreciation of Laura Burnside's commitment and dedication to this hospital. She's been an amazing partner for me as a CMO over the last 2 years, working in conjunction with patient experience and clinician engagement. And Laura, you'll be sorely missed, and we appreciate all you've done for JPS. Okay, let's get the next slides up for Leapfrog. Is that me? Just, okay, there we go. Thank you. As you know, Leapfrog is a hospital safety grade. It's from A through F. There's 2,600 general hospitals involuntarily receive a letter grade from Leapfrog 2 times a year. It measures 27 national performance safety measures that indicates how well a hospital protects our patients from preventable errors, injuries, and infections. The data comes from CMS, which is about 2 years old and available to any reporting agency, but it also has the most current Leapfrog survey. So if no Leapfrog survey was completed, they use other supplemental data sources, but we have submitted all of our Leapfrog initiatives. This is it's kind of small, but it is our final grade now for the fall of 2022 is again another B. We're just missing that A grade again that we got in the fall of 21 for a few things that I'll show you on the next slide. Although it's really small, and I just want to outline the fact that red means that those are areas that we are working to get back up. I'll address the hand hygiene, which is the area of improvement that we really want to commit to coming up, which, as you can see, has dropped down to 40. Now, 40 is not necessarily a percentage because for the hand hygiene, it goes from 100, that's amazingly good, to 70 to 40. So we've dropped back down, and I'll talk about that. The other areas you can see mostly the HCAPs as it relates to nursing communication, staff responsiveness, discharge information. We're pretty much extremely similar to our scoring from the spring of 22, slightly down a little bit on discharge information. We did bump up a little bit on the HCAP 6 discharge information, and we still need improvement on falls and trauma. All the other areas were actually in the green and above the national mean score. So so there's our score of B. Let me just focus on the hand hygiene. As other organizations improve, the national mean scores increase, and you can see by our scores that we've really decreased very little, less than 1 point in one area, and there's a lot of other areas that we've improved. From hand hygiene for spring, fall 21 and spring 22, Leapfrog was still providing grace periods because of so many patients that we had taking care of COVID with traveling nurses and et cetera, that the scoring was not as aggressive as it is now. For the fall grade, they returned to their normal scoring areas. So we looked into this, took a deep dive, and the areas of opportunity that have been corrected already or are in the process of being corrected are first validating hand hygiene training upon the hire, so that everybody that gets hired here in the new employee orientation knows the importance of hand hygiene and how to properly do hand hygiene. We did also notice that there were some rooms that did not have a dispenser in front of the room or in front of each bed and bed space, and we are ensuring that that's in place and added dispensers to the specific areas. Interestingly, our MRSA levels increased from 0.175 to 0.399, but that's still better than the national average. Any questions regarding our Leapfrog score for this fall? So I think there's multiple questions that are involved in that. Jen, can you tell us all the questions, or Laura, do you have those?
There are 3 questions in that domain. One of them is about, they're the same questions, they just replace the word doctor and nurse, yes. It's about listening, explaining, and courtesy and respect. It's those 3 areas.
How are those correlating to this one?
That says,
Does that have any?
yes, it's exactly right, yes.
So that influenced from those particular questions?
That's correct, yes. And then also what happens on the leapfrog score is there are deductions that are taken before it's published here, and so we don't show that in here. It's a calculation that happens, but that's exactly why empathy is one of the top priorities there, yes.
Okay, all right. Are we, since these scores have dropped just slightly, I'm all like, are there any improvements that we're
Yes.
making? What are we looking at?
Yeah,
Is
these
it-
scores are actually delayed, so they're from last year, so yeah, absolutely.
Okay.
You're getting good, Amanda. It's impressive.
Yeah.
So I think the moral of this story is that we continue to do well with our quality. B is really very, very good. And so I'd like to continue to commend the teams that work every day to improve. We know we still have work to do, but we are well on our way to every day improving and striving towards excellence in this area.
Well, we had to address COVID during this period also. So I would say some of that had to do with scores maybe being down too.
So I'm sure the team is very happy to hear you speak about COVID and the challenge we have, because I often say, okay, team, we're going to do this despite COVID. So I think that really speaks to, as Laura mentioned, just the culture of the team that, yeah, we may get these hits by something unforeseen such as COVID, but it still is our job to ensure and not use it as an excuse when it comes to patient care. So thank you
I guess
for
my
recognizing.
surprise was hand washing, because during COVID, I would have thought that would have went up, because we were really conscious of hand washing and sterilization and all of that. You know, we would running and buying everything out the store that we could spray and wash hands with. So I guess I was a little surprised at that one. Okay.
All right, any other questions? So we will move on to considering quality matters requiring committee actions and/or approvals. First one, QAPI, Jen Fondon. Welcome.
I've not had the pleasure of meeting all of you. Jen Fondon, I'm the Executive Director of Quality. So I bring forth to you a review of the Quality Assessment and Performance Improvement Plan, the QAPI plan. And this revision has been approved by the Quality Committee as well as the Medical Executive Committee, and it's being brought for your approval. It's been rewritten to ensure that these plans truly encompass the entire network and not just what it's previously been looked like as it represents just a committee. This plan also now has been rewritten to meet both Joint Commission standards as well as CMS requirements. The content itself has not changed, but we have added some key additions which are located if you, on the top bar, it tells you the page numbers. It's actually pages 9 through 11. And what these really reflect are our JPS long-range strategic plans, evaluation of our key priorities from the previous year, improvement projects which will be reported annually specific to our strategic and key priorities, identification of current year network priorities, and then identifying upcoming key priorities in which the Quality Council will be specifically looking at and evaluating. So it's a little bit longer, but we've added the attachments so that anybody who's looking at this throughout the network knows specifically what we're doing, why we're doing it, how we're doing it, what we're going to be measuring, and everybody is on the same page then.
Yeah, so I want to thank Jen for bringing all the quality work that's done across the organization in behavioral health and ambulatory. A lot of work was being done on separate committees within those areas, and she brought that all together to say that this is a network plan. So again, the content has not changed, but she has brought it together so it aligns with our strategy and works together across the organization.
I just have one question under D, Patient Safety and Quality Governance Committee, and the development of autopsy selection criteria and monitoring autopsy performance. We are defining it, and they go to the medical examiner's office. Is that what I read that to me?
The patient safety and quality?
Yeah, that's the section is under D. I have it under, my book is page 46. If I'm looking at the top of yours, is page 4 of 12.
Okay.
And I'm just asking on that statement, develop autopsy selection criteria and monitor autopsy performance. Are we defining what we are doing autopsies on, and they are done at the medical examiners? I'm just trying to figure out how they tie into us.
For the autopsy, so if there's an issue that comes up and then it requires an autopsy, the Patient Safety and Quality, PSQG, if they identify and say, this probably needs something that needs to be looked at, they may identify that and say, yes, we should be doing this.
Dorothy, if I may, this is a Joint Commission requirement that the organized medical staff has oversight and authority for the approval of autopsy criteria, so when an autopsy should be obtained, when we should seek permission. We obviously base that on the medical examiner and Texas state law requirements. That's top line for us. But once you get through that, there can be other reasons for medical autopsy. And so the PSQG is the organized committee of the medical staff that has oversight of that before it rolls up to MEC, if that makes sense.
Thank you.
You're welcome.
Any other questions?
No,
But I thank you for reading it, though.
Oh, yeah.
I appreciate that, so.
All right.
So we have three items that are going to require approval. I'm happy to break them out one at a time if anybody prefers, but if not, we could do all three at once. Any concerns over this one?
No.
Okay. We'll go to the next one, the point of care laboratory testing. Joy Parker. Welcome.
Hey, good afternoon. I was smiling at Dr. Miles because this is the life that she and I live together with point of care testing and microscopy and everything, and so she's a great partner, leader really. So for your no crime, Dr. Miles, no crime, just partner. Strike that from the record.
I thought, oh, okay.
Just all partners. So Dr. Miles will keep me honest on this policy. But yes, good afternoon. So for your consideration is really some minor red line changes to the verbiage. Essentially, it basically is stating that the Joint Commission is approved by CMS to make sure that we're adhering to all the CMS standards as well as the CLIA requirements. And so all of those align. And this is around the chapter within the Joint Commission of wave testing. So very minimal verbiage modification to that to clarify that for point of care.
Any questions? All right. Thank you very much.
And many people call me Jill, and I answer to that as well. So I'm actually filling in for Jill for this next policy around patient education. So this, again, as far as review of our policies, there's a minor revision here to adhere to the Joint Commission standard as it relates to patient education in that PC provision of care chapter. So that verbiage is verbatim from the Joint Commission standard. That's the update for that.
Any questions for Jill or Joy? Or Jen? Okay. All right. Thank you very much.
Thank you.
So at this time, I'll entertain a motion to approve what is before the committee for the QAPI, for the Point of Care 100 and the PC 700.
Second.
Moved and second. All those in favor signify by aye. Aye. Any opposed? Motion carries. Next will be to reconvene in executive session.
that I get my little cowboy boots out and start wearing them.
So that was part of it.
Reconvening in open session. Anybody have any other concerns or discussions? If not, I will entertain a motion to adjourn. Second. Second? And
So move and second.
second. All in favor, say aye. Aye. Meeting is adjourned.
I went to Georgia and they had with calling our meeting to order. And we have no citizens wish to address us. I do not have a quorum, right? Is that what you're telling me? So we will skip the minutes, and we will go into Dr. Elliott. You will just do your review.
Sure.
And we'll have to get those approved at the full board.
Sure. Happy to do that, Mr. Bose. Thank you, Madam Chair.
Okay.
All right, well, I'll go ahead and go really quickly, and then, of course, if there are any questions, please feel free to ask. Thank you for the opportunity again this quarter to present what we're doing here in Medical Horizon in terms of academic and research here. I'm also utilizing this opportunity per the Accreditation Council for Graduate Medical Education, our biggest accrediting body for our programs, the ACGME. We usually like to do an annual institutional review. I presented those documents to you also, and we'll just go kind of fairly through those, and of course, if you have any questions of those, please feel free to ask, and I'll go ahead and present that for an action item at the next board meeting, as Mr. Bose said. All right. So we'll start with the annual institutional report. Just want to highlight a couple wins. We're really excited that we actually have had 2 new fellowship programs accredited by the ACGME. We actually have our hospice and palliative medicine program. We received that accreditation back in 2022 and just recruited our first class of 2 fellows that started July 1st. Coincidentally enough, we have that site visit this week. And so we're doing a virtual site visit by the ACGME this Wednesday, and so we'll look forward to highlighting our program and hoping for a good outcome there. But we have received our initial accreditation, and they'll kind of get to know us a little bit more this week. Psychiatry, this is a huge win, not only I think for JPS and what we do here for the county, but it's a win for the county and all of our patients in our community that we serve here. So we now have a child and adolescent psychiatry fellowship program approved. This is really great because not only will it serve the needs for the mental health needs of our child and adolescent population here in Tarrant County, and working very collaboratively with our psychiatry department. I want to thank Celia Baugh, Dr. Pottlewell, our new program director, Dr. Colon, and all the folks involved in it, and Dr. Duncan, of course, with all the help and support for this, and Dr. Becker, because this is really critical. And I think what's going to be great about this also, it'll help us with our retention also, because oftentimes in the latter years of the psychiatry residency, we have our residents who want to go on and do a fast track into these fellowships. So the fact that we're already getting a lot of buzz around this, we're in the middle of recruiting for this to start July 1st, 2023 with our first group. It'll be 2 fellows for 2 years, so a total of 4 over the 2-year period for a 2-year program. So more to come on that, and I'll keep you posted as that continues to grow and when we get our first class next year. But that's, we've been hearing even great things from our partners at Cooks and others just thanking us for doing this. So. And then also, of course, we are pleased to have also received our expansion grants that were awarded and continue to receive that. We received over $2.5 million over a biennium to support our psychiatry and our family medicine program. So that's an increase even from last year. So we're continuing to look for that and hoping for good things in the next legislative session. We'll go ahead and try again after that biennium. Next, we also just are really pleased, and I know you're going to probably hear more in the future, but we continue to hear good things from our faculty around their engagement and just their commitment to teaching and the education mission and what we do here. And so I think we attract excellent folks here who have that mission of teaching, and so we just want to say that continues to be a win to engage our faculty in these areas. With regards to recruitment and retention, these are ongoing efforts that we have here. I think some things I will say, we've definitely done well in our recruitment of residents to our programs from students. We continue to fill our slots. Geriatrics continues to kind of look at ways to fill those slots even more. I do think with the hospice and palliative, it'll continue. It'll actually help us in those areas too as that becomes more competitive. But I will say, also we're gaining a lot more national visibility at JPS. One of the things we've talked about, and I've mentioned at this committee before, our efforts in our diversity, our DEI initiatives to try to really expand that. And so we're participating in more national fairs with our Student National Medical Association, Latino Medical Student Association, our HBCUs, our HSIs. We're trying to find these organizations that we can go to really highlight that. And we're getting actually pretty much good traction on that, and we're going to continue to track that because that's just some recent events we'll track over the next few years. But it's great to see that visibility happen and some of those kind of recruitment efforts there. We're going to go ahead, I'll talk a little bit more about retention coming up, but we're going to continue to work on that. We had a bit of a dip in that, but that's actually something that I'll explain a little bit later why we think those trends are happening. But we're going to be working on a strategy with our medical group partners to really be focused on how we retain even more here at JPS and within Tarrant County. And then research and scholarly activities continue to thrive and increase, and I'll show you a little bit more about that at the end.
Dr. Elliott, could you tell us just a little bit more about the fellowships? This requires, this is a fellowship after the physicians have attained the minimal training, right? So they can
Yes.
either go through family medicine or internal medicine, is that correct? Or is there others?
There are others. So for hospice and palliative medicine, they can usually either go through family medicine, internal medicine, emergency medicine. They have to complete a first residency first, and then they apply to come in. They can also go through other fellowships. We actually have one of our fellows who did not only medicine and geriatrics, actually fellowship, and then is now also going into hospice and palliative.
So that varies either 3 to 4 years?
It varies, yeah. Prior to that, they can anywhere from 3 to 4 years or 3 to 5 years.
Thank you.
You're welcome. Just as a review also, just letting you know, we have fully accredited programs across the board, including the 2 initial accreditations that I mentioned for the 2 fellowship programs. Just wanted to highlight there you see some of our program directors there, date of last site visit. We're still in the site visit window for several of our programs. I mentioned to you hospice and palliative is coming this week, November 16th, but we are also been in the window for quite some time for family medicine, geriatrics, and sports medicine, and so we look forward as we look to hear that notification there. Also, we are likely going to be looking at a site visit for the institution next year at some point, and we'll be doing some continual readiness around that. We also did have commendation for several of our programs here from the ACGME, including the 6th year we've received commendation as an institution, and then commendation for emergency medicine, family medicine, geriatric psychiatry, sports medicine, and transitional year. Of note, a couple program director changes on that. You'll see we had Dr. DeMoss, now program director for psychiatry. Dr. Kalan is the new program director for child and adolescent, as we mentioned. Dr. Hadley is our hospice and palliative medicine director. And Dr. Janine Ratliff is our transitional year director now, as Dr. Nelms retired in May. Okay. Next, just talk a little bit about our board pass rate. We usually mention this too. We continue to maintain an institutional average above 95%. We had most of our grads except 2 that did not pass, 1 in geriatrics. Unfortunately had some very significant personal challenges and with COVID, so we support him hopefully in his retake as he looks ahead. He's already graduated and moved on. And then psychiatry, just 1 resident. But overall, we continue to maintain an institutional average of 96% and higher. Talk a little bit about our graduate practice locations. As you see here, we normally trend, and I present this data to the board usually in terms of our Texas and outside of Texas data. This was the first year we actually saw just a slight shift out of Texas in 2022, this past graduating class. And we're waiting to see what the national data looks like for 2022. I will say some of the comments that we've kind of heard from our graduates were, some of them were kind of a COVID effect, actually. They were feeling they wanted to go back and be closer to family, depending on where family was located. They also, some of them actually are just taking some time off, and they're waiting to be credentialed a little bit later. And so now they're getting into the credentials, so they didn't necessarily want to kind of commit to a position at the time and just needed a little bit of time with that. And then I would say, there were comments, and we've heard from our residents and some students, just some challenges around some recent policies that may affect the way we practice in Texas. So that is definitely contributing according to that.
Could I ask you a question about?
Yes.
What is the percentage of our residents that are not from Texas? I mean,
yeah, usually it's more from Texas. So actually, even that class majority, we still trend with our incoming data that most are from Texas. So over 50% are usually from Texas.
okay,
Yeah.
all right.
Yeah. This is also just data that I usually present also, just to let us know kind of our retention of our graduates here at JPS, then also in Tarrant County, and then DFW Metroplex, and like I said, just kind of breaking that within Texas and outside of Texas data a little bit more so. We like to see above 10% here at JPS, but of course I mentioned those trends that we kind of saw a little bit of a dip, even in Tarrant County, like I said, just a little bit of a dip there too. And then in the DFW Metroplex. Overall, we've got about 11% or so in Tarrant County area and about 30 to 31% overall in all of DFW. That includes JPS, Tarrant County, and DFW. And so what we're looking at, we're going to follow this closely. As I said, I'm looking forward to kind of seeing what our data will be nationally and some trends there. I am looking forward to working with our physician groups. I know Dr. Becker and I have spoken to say, how can we come up with a strategy and kind of looking at ways that we can really work together with his team and my team and our chairs to really work on looking at ways to increase that demand a little bit more. I do understand that some of the gaps may also be that some of the specialties were not necessarily, the specialties that were in demand weren't necessarily ones that our graduates were in, but we also want to make sure that we continue to look at what our graduates are doing, and those that want to remain, we start to follow them early in their residency and track them throughout to create those opportunities. I will say one other measure that we started measuring this year based on our strategic plan and working with that was actually in the overall looking is at those JPS grads or those affiliated programs that have returned to credential here on our med staff that graduated within the last 5 years. So we're going to start to track that. We just tracked that for the first year this time, looking at all of our newly credentialed doctors in the last year and see who were affiliated, whether they were a JPS graduate or with our surgery integrated program with Baylor University Medical Center or with UT Southwestern programs that we also work with closely. And we found that we had about 12 returns. So we had about 10 to 11% of all newly credentialed med staff in the last year were actually trained here, so in the last 5 years. So we're going to start tracking that also in addition to that. And I think that's a good thing to see people are returning to. Yeah.
Like, what were some of the other reasonings? Were there things that we could have done to increase that, or is it just, again, like you said, family, COVID?
Yeah, I think it was mostly all of those things that I mentioned kind of with the Texas, non-Texas effect too. Some, like I said, taking some time off, some saying a little burned out, wanting to kind of take some time and looking at that and just going elsewhere. Some are actually doing even temporary work too, just doing some locums and things like that too, interestingly enough, until they figure out where they're going to settle. That's why I think it's going to be important to track that number coming back in and see if we can bring them back in.
And that age range is usually what, 20, that age range is usually what, 25, 35?
The age range for our graduates, yeah, 25 to 35, yeah.
Dr. Elliott, were there fewer openings at all?
Yes. Absolutely. Great point, Dr. Duncan, great point. Yes, the demand was definitely.
I think there was some of that, because it just wasn't as much.
They weren't as much, yeah. They weren't as many. Any other questions? Thank you for that. Okay. All right. Just a reminder that we are also in the clinical learning environment review window. Our last visit was 4 years ago, so they will be notifying us, giving us about 2 to 3 weeks notice that they'll come for a 2-day site visit. We are actively working on this, of course, and I've presented this prior to in these 6 key areas. We have a project manager, Ms. Tessa Watson, who is incredibly skilled in the areas of patient safety, healthcare quality, and teaming, and worked as a nurse and also with our peer review process in the past and with quality team. And so she's been really leading the efforts on the team and working collaboratively, and more of those details are in our report that are in the board documents that you can see around those clear activities that we've been doing and working together on. So just wanted to keep that in your forefront of your mind.
Dr. Elliott, when they come in, do they go back and look for programs in the past, how long they've been in place or just what you have in place now?
They are just looking at what we have in place now and how we've progressed since the last one. They're also looking at kind of national data and how we're comparing with that. And it's actually what they like to say, it's more of kind of this kind of PDSA model for us. They want to show us opportunities for improvement and highlight our best practices too and share those. And so they'll also be doing some component virtually, but they're actually going to be coming on site, and they're going to be doing some walk rounds also. And their key things is that they have to meet with the key C-suite leaders, so Dr. Duncan, myself, and then we'll invite some other of our key C-suite leaders. They want to have that component to make sure how the hospital is gauging, ensuring, of course, the support with the board and how we're doing all of this. And then they'll go ahead and have individual group meetings with like the program directors, the residents. We'll coordinate all that like we did the last time too, and then they'll do some walk rounds too. I think one of the interesting things this year that's new is the teaming pathway, and so we'll be working, we've been kind of talking a little bit with Jill Farrell and talking about that, and we're going to be looking at ways to highlight some ways to expand teaming. What was kind of fun this year is that we actually, this intern class, when we did our orientation, we did our first Team Steps program, but the nurse residents and the interns got together and did some team steps, and they did it for a whole afternoon, and it's a lot of fun to watch them work on that. So we're hoping we can build on that so they can see the power of teaming with their interprofessional team. All right.
Does CLEAR give a rating? Or do
No.
they give a grade? Are there grading
Yeah,
systems?
no, there's no rating at all, actually. It's not even a pass-fail rating. They're just saying if you don't do it, then you're in trouble. But they just basically give you things in terms of, when they come, they do an audience response system, so they kind of get a sense of what percentage we are in terms of compliance with the questions that they're asking for, but there's no rating. All right. And so just to wrap up, and you'll see these in your document that are attached, is that we had our institutional priorities. So we're going to continue to really make sure we're getting this continual readiness for our accreditation site visits. We presented our institutional self-study last year, and we're continuing to monitor those, of course, and those action plans. We are also always looking for opportunities for GME growth, funding, and collaboration. So, of course, working very closely with our physician groups and our finance department to be able to help us with that and look at those priorities around that, too. So that will be something we're continuing to work on as we've grown. Definitely, we've grown for sure over the last several years, and we want to continue to grow in those specialties and those areas and those fellowships, too, that we need to in residencies. I mentioned to you also, we're going to kind of look at a strategy around our, how do we actually increase retention of our graduates and look at that. So we're going to have a thoughtful way of working with the claim and our folks to be able to do that. And then I think to also enhance the diversity and inclusion in the recruitment of our residents and our faculty. One of the things we do hear from our students coming in is that, one of the challenges around that is definitely seeing more diversity in our faculty. And we hear that repeatedly. I've heard it personally from several when I go. They want to see more of that. They want to see themselves reflected. And so I think if we can also focus some efforts with our physician group partners to expand our faculty diversity and to highlight it too very visibly around that, that will also help us in terms of our recruitment of our students to our residency, because that is a factor that comes up repeatedly. So we're going to add that to our strategy, working together on that too. And of course, working with our HR partners on our DEIB, the Diversity, Equity, Inclusion, and Belonging, and we'd love to see that also, of course, be a part of our residency program. So I'm working with Carla as she leads that effort, and then, of course, I'm working with Dr. Duncan as we look at health equity too, and just how we can incorporate this across the board. And then we did centralize our grants office into the Office of Clinical Research. And so how do we continue to build that, expand that, and build that team? That team is a brand new team doing this work. We'll talk a little bit about what they're working on upcoming in this presentation. But it's great to be able to just do this work, and we've got some things in place, and it's going to take some time, but they're already busy. So I'm really excited about that centralization of that. And we're also working with our compliance team too around this. All right. Any questions before I move into the next portion of our committee agenda? that's our report, and I will go ahead and just, like I said, at your direction, Ms. DeBose, bring it forward to the board for an action item. All right. Well, I'd like to go ahead and ask Dr. Glenda Mutinda to join me here. And I know at the last Medical Horizon Committee meeting, you mentioned wanting to hear a little bit more about what are we doing in the areas of well-being, and how are we measuring that, assessing that, doing some interventions around that, particularly for our residents. And I thought it would be just the best thing to be able to bring Dr. Glenda Mutinda as part of my team. She's one of our directors here and Director of Interprofessional Wellbeing on my team in Academic and Research Affairs. I've known Glenda for many years, even when she was an intern. Yes, and she's grown and done exceptionally well. Been here at JPS now for 4 years this month, just celebrating her anniversary yesterday. Yeah, so 4 years. And really, when I told her, I said, hey, Glenda, I've got an idea. I want you to build something. Let's do well-being and make this, we have all these national efforts on how to do this and accountability accreditation to do it. Let's make this really happen. And she's been phenomenal in doing this. And she comes with great credentials in terms of not only her doctorate in medical family therapy. She's a licensed marriage family therapist in medical family therapy. And she has been involved in advanced fellowship training in residency education and integrated behavioral medicine. So she is highly, highly skilled and a great collaborator, I will just say. So I'm so happy she's here. I am asking her to do the next set of presentations, and we'll turn it over to Dr. Mutinda.
Thank you so much, Dr.
And
Elliott.
you can press that little button right there, and there you go. Oh, but put it one more. It's green. There you go.
There we go. Thank you so much for that wonderful introduction, and thank you all so much for having me this afternoon to share a little bit about our well-being efforts and how we've been able to capture that for the last few years that I've been here. And so, we really define well-being to comprise of several key areas, including physical, emotional, psychological, spiritual, financial, and intellectual well-being. And so a part of that effort is assessing our residents and fellows and seeing how they're doing. One of the measures that we use is the MASLAC Burnout Inventory Toolkit. And it is made up of 2 surveys, the MASLAC Burnout Inventory, which you will see the results here on your screen, and the other is the Areas of Work-Life Survey, which I will go over here in a moment. And so I really wanted to kind of show you 2 key areas. You will see on the left-hand side our intern data, and so this information was gathered at orientation. So before our intern groups have any clinical standings here at JPS, before they've stepped foot here, and just wanting to see what their baseline was and assessing probably the impact of going through medical school and all of their life experience up until now. And then on the right-hand side, you'll see our upper levels, which we define as our second years, third years, fourth years, and fifth year residents. And the reason we did that is really to ensure the confidentiality of the measures that we're using. And so we did not want to leave our fourth and fifth year residents feeling more exposed because there's less of them versus our first, second, and third year residents. And so I'll just go over the intern data first there on the left-hand side. And so what you can see is that in the blue, we have our 2019 interns. In the orange, we have our 2020 interns. In the gray, we have our 2021 interns, and the yellow, we have our 2022 interns. And how this measures, or how this tool measures burnout is with the 3 components: the emotional exhaustion, depersonalization, and personal accomplishment. The scale is out of 6, and the emotional exhaustion and depersonalization numbers are different from the personal accomplishment, meaning the higher the emotional exhaustion and depersonalization numbers are, the more likely someone is to experience burnout or symptoms of burnout, versus in the personal accomplishment, the higher the number there, the more protection they have against burnout. So interestingly enough, and this was surprising to us, is that our 2019 interns were at greatest risk for burnout based on how they responded to the survey, and our next following years of intern groups have been less susceptible to burnout. And they've been able to really give voice to some of the reasons for how they were feeling and experiencing life at the time. And what we have learned is that from the 2019 interns, what they said is that, at the time, JPS was extremely competitive on the national ranking of residency programs. And so they had worked extremely hard, traveled across the country to interview at different areas, and were really working their absolute best to make sure that they can get into residency. And some of that had significant impact on how they were feeling in terms of their susceptibility to burnout. And then as the next following year, so 2020, 2021, and 2022, there were varying degrees of virtual learning components involved. And so these were learners in the heart of COVID or at the beginning of COVID, and their medical schools really helped support their well-being by incorporating more virtual learning platforms for them. And that is one of the number one things that they have said this last 3 years group, is that virtual learning was a major protective factor against burnout, and having that readily accessible education made significant impact on them. And so they were really appreciative of their medical schools being able to do that. The other thing is that they mentioned is that there's varying degrees of well-being curriculum. And so some of our medical school students coming in come from medical schools with a lot of support, and some of them don't. And so we get varied degrees of familiarity with well-being and what well-being is and well-being initiatives. But overall, what we have seen in the last couple of years especially is that more and more medical schools are really, really attentive to this, and we can see the impact of that by how our medical students, now residents coming here to JPS, respond to the survey, but also speak about well-being. Topics like burnout and compassion fatigue are not new to them. These are practices that they've been used to during medical school, and so they come into this environment really well equipped to kind of cope with the challenges of residency. And then on the right-hand side there, you will see the upper level resident data. And so again, in 2019 is in blue, 2020 is in orange, 2021 is in gray, and yellow is 2022 upper level residents, again, second years through fifth years. And here we see that there's some variation in the emotional exhaustion pieces. And unlike some national data, actually, especially in 2021, our emotional exhaustion measure there actually went down versus other places around the country where they actually scored higher on that measure. We saw a little bit of that emotional exhaustion just go down a little bit, but come down even further in 2022. I will touch on emotional exhaustion in 2022 as well, that we've seen a little bit of an increase in that. And, a part of that is just working and learning in COVID and the impact of that. This year, we're seeing more people in general just experiencing that exhaustion, and our residents and fellows are no exception to that rule. But what is extremely promising to see here is that this year our upper levels are reporting the highest rate of personal accomplishment. And a part of that, they really say time and time again that being able to serve the communities that we have here at JPS, belong to the JPS family as a whole, has really been protective for them. And so they really feel incredibly accomplished for having learned and worked through COVID and still rising to the occasion. And so some of the, I will touch on some of, oh, yes, go ahead.
Sure, go back?
Yeah, absolutely. Yeah, so the Maslach Burnout Inventory defines depersonalization as kind of an unfeeling. For some, it's, they explain it as kind of being a shell of yourself, watching yourself go through the motion, but kind of being detached from that. And so that is, as I'm presenting the inventory to them, they do have those definitions in mind as they're answering the questions. Yeah, thank you. So the second piece here is the areas of work life. And so that assesses the 6 key areas that Maslach and her researchers have put together in terms of the contributors of burnout or wellness. And so the 6 key areas include reward, sense of community, values, workload, fairness, and control. And of note here, our areas of strength tend to be that alignment in our values. Like I mentioned, our residents really are proud of working at JPS, serving the communities we serve. They come here to do that work, and that stays consistent in their time here, and they speak very, very highly of the individuals that they are able to serve here. The second piece is reward, and so that is a number of things that really from the get-go with Dr. Elliott's leadership, being able to provide competitive packages in terms of salaries and benefits is really crucial to their decision-making coming here to JPS. But there's also program-level efforts of recognition, so our program directors, our program coordinators, their faculty work very hard to recognize their hard work and in the areas that they work in as well. We also have our own institutional celebrations, such as Doctors Week, and we also have our resident and fellow awards that are annual. And our residents also have additional days on top of their PTO, and we call those well-being days. And so they really value those pieces. Having a sense of community at JPS has consistently been very, very strong. And in fact, that sense of community has been higher when compared to other folks who have taken the MBI toolkit, and that is both residents and faculty physicians or medical staff. And then the last piece there is the support for mental health. And so we have several programs, but really having the accessibility to our employee assistance program, our spiritual care and ethics team, being able to have hard conversations and training such as the QPR suicide prevention training has really been critical to supporting their mental health. And the culture in medicine is changing. We're seeing people much more open to talking about it, but we also encourage those conversations here at JPS and empower our residents and fellows to utilize our confidential free services while they're here. So I will touch on the resident check-ins. So these are mandatory for all of our first and second year residents, and they are confidential sessions that they have with a licensed mental health professional. And since everyone is required, it's really great for destigmatizing mental health and helping everybody prioritize that. But we call it a check-in because it really is informal in the sense that we just want them to be able to attend to how they're doing, what's going well, how we can help support them, how we can help troubleshoot if there's anything like that, and then refer them to additional resources as they need them. And so what's great about the check-ins is that a lot of our residents will be doing well, and we're able to amplify the things that are helping them do well and also support those who might be starting to struggle or those who are struggling. So it's a great opportunity to attend to all of their mental health and well-being regardless of how they're doing.
I have a question. Y'all may not be able to answer, but maybe Dr. Miller will. So in looking at, Dr. Miller, really quickly, in the leapfrog scoring, the residents and interns, are they included into that leapfrog scoring? When they're...
In regards to clinician engagement?
Mm-hmm.
Yes.
Yes.
They're in it, and actually their participation was even better than the clinicians at this point. We'll share that data with you. But they're included and they can be separated, and we can see the difference between residents at different levels and clinicians that are full practice.
Okay, perfect. Okay, great. I'm just trying to make the correlation between the way that Press Ganey was able to identify the topic of empathy, but yet in this survey, there's a high sense of community that's being talked about running through. It doesn't it doesn't make sense. So I don't know how that pinpointing of empathy is coming through, whether it's the older or the longer-term physicians who are here, or how is that in respect to residents? And I understand there's also a level of excitement that comes with residency. You want to do more. You want to be that person that is constantly at the bedside. How do we contain and continue that movement going forward with the other parts and pieces of communication?
No, I think that's an excellent
overall
point. Yeah, no, that's a great point. And I think that's one of the things, and actually Glenda works very closely with myself and Dr. Miller too. We'll actually take the data, because now that we have the data available, we haven't had a chance to drill down into it, but those are the things we like to kind of couple and layer on. So there's several different kind of sources of input that we get for the residents regarding just well-being in general and engagement in general. So this, of course, the Gallup survey and doing all of that. So the clinician engagement survey will break that down. We'll be able to kind of tease it out. I think layering that with our MBI that we just presented to you and see where they are and look at the upper levels, see what kind of themes we have there. We also, usually about the last half of the academic year, between anywhere from January to March, we also have to do the national ACGME survey that's done confidentially too. Then we get that data usually April and May. They have a bit of well-being in that also. So we like to take all these sources, look at it to see what the themes are, where are we kind of in terms of each level of resident. And so we'll drill down a little bit, but it's going to take us a few months because we want to layer each of those layers. But I think that's exactly the kind of thing we want to think about.
Providers, our clinicians, on the well-being part of it compared to the residents. I think the residency program has done a great job in putting that infrastructure in place, really surrounding that resident and keeping in touch with them. And I think we still have a lot of work to do with our clinician group. If we could do that, I think we could get those closer together.
Okay, cool.
And I'll just say, I know, and probably Dr. Miller could talk about this at another time in a future time, but the med staff did just do a survey too, like you said. We've been a little behind, like you said, and so they're trying to initiate, just collected some data, some similar data using the Stanford data, right? And I know Glenda works with them to help them also, and it's going to be helping them guide some of that through their practitioner satisfaction committee and looking at their well-being and working with the physician groups too to see. So you're right. I think as that unfolds, we'll see how that layers too.
Yeah, awesome. Thank you.
Yeah, great question.
And then just looking at our areas of growth and areas of opportunity here, these last three stand out. So workload, fairness, and control. And one thing to point out too is that on a national perspective, while our scores for reward, sense of community, and value are higher, our scores for workload, fairness, and control are very similar nationwide. And I think what that really highlights is the need for national level initiatives to support healthcare workers in general, and our residents and fellows are a part of that, but really support physicians along their continuum of their careers. And so these areas, in order to do that, we've been, of course, in partnership with several departments here at JPS, and as we continue to work through these, I'm sure we will certainly have additional partnerships, but just at this point, working with department leaders to improve the workflows. One of the challenges certainly was staffing, and so as we have more staffing, that workload is likely to get a little bit better for our residents and fellows, but as well as everyone in the healthcare team, and really empowering and engaging our residents and fellows in leadership roles and drivers of change. They are extremely passionate and knowledgeable, and so utilizing them as key contributors to the healthcare environment has been really great. For example, we encourage and have residents as part of hospital committees, and they can be key contributors to those committees and have their voices heard there. In terms of DEI and DEIB, working with our HR partners, not only to ensure fair and equitable processes, but really to expand on the DEI of our team members overall and our DEI in academic affairs and in our residency and fellowship programs. And then the last piece there is just being able to provide opportunities for informal leadership or formal leadership. So we have house staff officers, we have chief residents who really take on significant leadership roles within their programs, as well as those residents who serve on several committees, but also for others to be able to have leadership opportunities such as Flipped Classroom, where they take on content and teach their peers and colleagues, is a way to just leverage that leadership opportunity for them a little bit more.
Okay.
You know, they want to know what we're doing, and I think this will highlight some best practices for sure. It's interesting enough as I go through the last few years, and we've built things like the resident check-in or the suicide prevention and harm, and now she's even building Stronger Together, the peer support program.
Facility alert, fire alarm activation, Tower 10, West Stair 10 exit. Facility alert, fire alarm activation, Tower 10, West Stair 10 exit. Facility alert, fire alarm activation, Tower 10, West Stair 10 exit.
There we go. The test of plain language, there it was.
All right. Thank you. Good report.
Yeah,
Okay.
so as we listen more. So yeah, I think it'll be very, very great to be able to highlight some of that. And it's interesting as we've been kind of talking about this and learning with our colleagues across the country, when they hear of some of the things we're doing, even like the resident check-in, we get a lot of buzz around it. They're like, oh, can you tell us more, what are we doing? And just knowing that the outcomes and it's helping. And it's just normalizing that mental health is part of who we are, and we need to check in with each other and help each other and support each other. So I think it's just been great to see that evolution. And I think you can see it from the data that you saw. You know, they're feeling more accomplishment, they're less depersonalization throughout, even with that. And residency is hard. Dr. Dutton and I look at each other, it was hard, and it's still hard. And so anything we can do to help them through that. So I'm very appreciative of our partner, my partner here with Dr. Mutinda to do this work. So thank you.
Okay. Thank you.
Thank
Good
you.
work.
Right. I'll go into a little bit more in the research highlights. We asked you wanted to see a little bit around where we were with clinical trials in terms of our numbers and our revenue and our grants. And so I'll go ahead and just give you a little bit more of that. So this is just in terms of our abstracts and posters. So Research Symposium, just highlighting the growth that we've seen there over the last few years. You know, we're now virtual on our Research and Quality Symposium, and we're now integrated with quality, which we love that. And I think this virtual symposium has been a win.
Attention please, facility alert, fire alarm activation, Tower 10, West Stair 10 exit, all clear. Attention please. Facility alert, fire alarm activation, Tower 10, West Stair 10 exit, all clear. Facility alert, fire alarm activation, Tower 10, West Stair 10 exit, all clear.
It's 3 times, yeah.
All right. It was a drill. Oh, it's good. Okay.
It's our new code system.
The new code, it worked. You did? Yeah. Plain language 3 times. I remember. So yeah, I think just of note, we're going to go ahead and keep the virtual platform. I think it's been successful, but we will look at some ways in this next year to see if we can bring some component of in-person together, not necessarily maybe to the full extent that we did before, but we'll kind of do a little bit of a hybrid approach. But I think the fact of being able to do these gallery posters and the way we did it, we're just hearing really great things, and it's really allowed us now to be national. And so we're getting a lot of great submissions there. So thanks to our Office of Clinical Research team on that. National presentations overall in terms of, or at the Research Symposium? I want to say we may have had about 10% of them might have been from out. Yeah, it was a significant number. Yeah, and I had a previous, I can bring it back, but I had a previous list of those institutions too that participated that were outside of Texas too. So it was good to see.
Great.
Yeah. And then scholarly activities, we continue to grow. I think FY22, we had, I think we grew a lot in FY21, let's just say that. And I think we're normalized more in FY22. I will just say that. But I do think that, there's probably a little bit of, a little tired. People are pulled in all different directions, and we want to still advance scholarship, and we need to do that. But I do think there's probably a little bit of some exhaustion and a little bit there too. But I think I'm so proud for them to still have that kind of output. I mean, that's pretty great to do that kind of publication and scholarly. So thanks again to the team working with all of our physicians and clinicians across doing this work. Then on clinical trials and grants, we have definitely grown significantly in our clinical trials, and we're hoping to continue to grow, of course. And so as you see here now in FY22, as far as clinical trials coming in and those dollars, we're upwards now a little bit of $1 million plus. We've had a significant increase from one year to the next, 6% increase. We do have some departments who continue to do really well, such as podiatry, surgery, internal medicine, doing some lung studies around COPD and asthma and COVID, and then emergency medicine. Podiatry does some things around wound healing. So we're working on this, and I think we're going to continue to grow. I think one of the things is ensuring we've got, our physicians who are engaged in this are really trying to make sure that our patients are well represented and have that trust. And so our clinical research coordinators also work very closely with our physicians and clinicians across the network to do this and enroll them and to make sure we're doing things that are thoughtful and helping our community too.
So on that, when I'm looking at your number of clinical trials, are these new clinical trials or those new ones and old ones, you just rolling them forward?
Those are cumulative too, as we're looking at that.
Okay.
And some roll off and some roll new and some expire too.
Right.
So those are as we keep the ones that are continuing to grow and then those that we've added to.
Add a slide that shows the number that you've actually closed so that
we can do that.
Yeah. Okay.
All right. And then with regards to our grants, looking at our total grants too, as I said, we just centralized this process. So, still working on it and looking at that. We did that in May and June this year. And so, but we have grown. And I think as we're looking at that, this is a rolling number as we look at that with 38 grants and looking for more. I think we did have a significant increase from FY21 to FY22. I wouldn't say that's a normal trend. We're going to hopefully look at about a 5 to 10% and work on that each year as we're looking ahead and looking for those opportunities. We're about in that grant cycle. Grant cycles are very, varies throughout the year where we are in terms of those submissions, but we're definitely going to, as we do this and have our team work on this, they're scouring for those grant opportunities, of course, vetting those across the network, across the 3 areas we always look at it, and Dr. Duncan and I talk about this, and Sharon too, and we make sure we work with our teams, our finance team, very closely with this, and we look for things around alignment. So strategic alignment, the feasibility and cost around this, where we are in the sustainability for this too. So those are kind of our 3 factors that we always use to vet these opportunities also.
Okay.
And last, just a reminder, presented already before around the IRB and our partnership there with the North Texas IRB and UNT Health Science Center. Just wanted to bring this forward in terms of looking at our new projects versus our continuing projects and our modification projects. We're at about 250 plus projects right now that have been under review, and we will continue to monitor this closely. We do have our participants on the North Texas IRB on the board. And we're also looking to maybe even add some women's health. I think we want to look at some opportunities around that. So we're going to be working with our women's health leaders to see if there's any opportunities to add that to the board. And then, of course, our nursing too, working with Jill Farrell on nursing representation too there. And that's where I wanted to leave us off and summarize where we were.
Okay.
Thank you.
What is a modification project?
Yeah, it's where basically we've had some that needed to kind of think about a different direction. So they may have come in and said, okay, we're QI or we're research. We need to kind of shift gears a little bit and kind of redirect them in terms of modifying those projects to ensure compliance.
Oh, okay. All right. Thank you.
You're welcome.
All right. Is there any questions, Dr. Young?
Do you think we'll continue with our own independent IRB?
Excuse me?
Will we continue to have our own IRB?
Well, our IRB is a collaborative IRB. We do not have a JPS sole institution in IRB because we had kind of mentioned the fact that this is a much better model, partnering with an academic center around this. So I think this will be a model that we will continue because it's helping us meet those compliance and those regulatory, but it's also really allowed us to grow significantly. And our cost actually is lower when we do it, comparing it to if we were to utilize commercial IRBs or other IRBs. This is actually a cost savings, which I actually presented to the board just the last bit. So I think we'll continue this model, this collaborative model for a while. And we just renewed our agreement too.
But even with the collaborative model, you almost have to have something here.
Yeah.
Kind of your
So
own
that part,
semi.
yes.
That has to
That
stay.
we will always continue. We have a research integrity team, and we make sure that it is compliant for us fully here. Yes, you're absolutely correct, Mr. Bose. We will always need to make sure we have a research team here on site and a research integrity team, and that's why our Office of Clinical Research is critical for that.
Thank you.
All right.
Thank you.
Oh, yeah, I'm very interested in that one. I mean, when you start doing more research and with other
Yeah.
folks, I need to make sure that for this organization,
Yes.
the patients and employees, we are protected. Yeah.
Absolutely, absolutely. And we're actually, like I said, working also with our compliance team too. We always make sure that we have that audit and making sure we're meeting those needs.
Okay.
I fully agree.
Are there any questions or any other business anyone have? Okay. Then there being no further business, then we are adjourned. Thank you.